It is usually caused by muscle or tendon moving over a bony prominence, and it's particularly common around the hip. As I said, whilst it is normally harmless and painless, it can be very annoying, and it can lead to soft tissue inflammation such as bursitis. The first and commonest location for this is on the outside of the hip, and this is due to a band of tissue called the iliotibial band, which can flip over a bony prominence of the hip, which is called the greater trochanter. This is very common. Secondly, you can get similar symptoms at the front of the hip, and this can be due to two major muscles, either the rectus femoris, which is one of the major muscles of the thigh, or the iliopsoas muscle, which is one of the most powerful hip flexors, both of which can be irritated over the bony prominences of the front of the hip, causing these symptoms. Thirdly, you can get symptoms at the back of the hip relating to this, usually caused by two main muscle groups. Firstly would be the hamstrings, which originate on a portion of the pelvis called your ischial tuberosity, and they can flip over this bony prominence, causing symptoms. Secondly, the other major muscle is the piriformis, and this is a deep muscle from your pelvis, and this can irritate over bony prominences as it tracks its way out of the pelvis to attach to the top of the femur. It's usually exacerbated by sports with a lot of hip bending, and it's often seen in adolescents due to the fact that their bony growth, their height in the growth of their skeleton, outpaces the growth of the muscles and tendons, and therefore makes them prone. So that, in combination to muscle tightness, is commonly the underlying cause. 90–95% of treatment for a snapping hip can be done with physiotherapy to work on muscle tightness. As mentioned, a whole group of muscles can be involved, including the iliotibial band, iliopsoas, rectus femoris, piriformis, all of which get particularly tight, particularly commonly tight in runners. In cases where symptoms persist, a targeted steroid injection can be considered. Usually this needs to be done under image guidance such as ultrasound or CT. Thirdly, and quite rarely, surgery can be considered, which can be either done keyhole or open, but this is probably less than 2–3% of cases.